would like to thank everyone for joining us today. My name is Dr. Musha Mustafa, and my topic will be on the ocular trauma. This will be an overview of my presentation, so I will briefly uh, mention about the relevant anatomy pertaining to our topic today, briefly go into the classification that we use for ocular trauma, and finally into making the diagnosis and how we manage those cases. Now, this is a cross section of the eye, so let's go into the relevant anatomical structure of the eye. So this is a cross section of the eye. We have the anterior part of the eye, which involve the cornea, the iris tissue, the pupil, the lens, and the anterior part of the vitreous. And we also have the posterior segment of the eye, which involve the vitreous cavity, the vitreous gel, retina, choroidal layer, as well as the optic nerve. So the eye is actually surrounded by the sclera, very strong tissue, as well as the cornea. And the thinnest part of the sclera is somewhere just behind the insertion of the muscle. So these are the common causes of injury. We can have the domestic injury, especially when it involves kid. Basically, as simple as penetrating injury because of the pencil. It can also be caused by the mechanical pencil, and commonly as well is the toy bullet related injury. Now, when it comes to hobby, it could be a penetrating injury by the fish hook. Commonly as well is the shuttlecock injury. Shuttlecock usually does not cause a penetrating globe injury, but it causes more of the blunt trauma effect on the eye. And word related, as simple as nailing without having an eye protection, and as well as the windscreen injury in a motor vehicle accident. Now, under the miscellaneous is I would just like to mention about this chemical injury, in which I will not be able to cover during this session since we have a very short session today. But I would like to highlight that if you have a patient with chemical injury, at least what we have to do is don't take a long history. Immediately irrigate the patient with 5 to 6 pints of clean water. In our clinic, we use the balanced salt solution, but in your own clinic, even the normal saline would do, as long as you quickly irrigate the eye, wash off the chemical, which usually sits on the surface of the eye, or actually sometimes underneath the eyelids. So wash it as much as you can and as fast as you can. Now let's go into the classification of eye injury. We use the Birmingham Eye Trauma Classification. It divides ocular injury into the closed globe injury and open globe injury. Now, for the closed globe, what it tells you is it is describing when the injury occurs but the sclera is still intact. Injury mainly comes from the contusion of the eyeball as well as stretching of the eyeball. Now, there are also situations whereby there is lamellar laceration, so it is not a full thickness laceration, and when patient also presented with superficial epithelial defect, that is also will be considered under the closed globe injury. In other words, the structure of the eyeball remains round, there is no collapse of the eyeball, and the sclera remains intact. Now, for the open globe injury, it consists of what we call a penetrating globe injury. There's only one particular wound, which is the entry site. And another situation, we have the perforating globe injury. In these circumstances, we have the entry wound and we also have the exit wound. So we have to deal with two wounds. And another classification come into play is when a patient has an intraocular foreign body. Now, what are the common complaints when a patient is involved with this ocular injury? It can be as simple as asymptomatic, no complaint at all after the incidents, but certain complaints should be taken very seriously. For example, when a patient comes with reduced of vision, so they can't read the Snellen acuity, normally they should be able to read up to 6.6, but in this situation they might be able to see maybe just counting finger. They can't even see the Snellen at all, or they might be able to at least read half of the sentence, is also a warning sign that we should take things seriously. When the patient complained of a very severe eye pain, so sometimes it can be very severe that they can't even open the eyes. Redness of the eye, which can either mean a simple subconscious hemorrhage, or it could tells you there is some perforation of the globe. Sometimes we have patients, come to us with this periorbital hematoma, and they can't open the eye by themselves spontaneously. So in this situation, also we do encourage doctors to actually refer those cases immediately to the eye doctor for further evaluation. Now, the other situation is when the patient start to complain of seeing floaters, which means they start to see something moving in the field of their vision. The object seems to move with the movement of the eye, right? So that is what we call floaters. So if the patient has floaters, acute, sudden, after any kind of injury, so refer the patient immediately. It might tells you that the patient has vitreous hemorrhage, or the patient might have a retinal detachment. Now, another situation is when the patient can actually specifically tells you that some part of the visual field is a bit dark. The central vision might still be good. They might be able to see 6/6, but at the same time, they might complain that some part of vision is very much reduced. And sometimes they can also tell you that the central part of the visual field is dark, and they always describe, like, they can't see your face, but they can see your ears, they can see everything around you, but not your face in particular. So this is the central scotoma, which might tells you the patient might have a optic neuropathy. In our own eye clinic, of course, we have the facility of our slit lamp, but in a general clinic, I'm sure at least you will have these two instruments, a bright torch as well as an ophthalmoscope, which usually comes with an otoscope. Now, how do we use the bright torch to assess the eye? So we will ask the patient to open their eyes, if they can do that. Look at the surface of the eye, look for any bleeding. You should be able to see, if let's say there's a subconjunctival hemorrhage, you should be able to see the end of the subconscious hemorrhage. Try to evaluate the age of the subconscious hemorrhage. Look at the shape of the pupil. It should be round. If the pupil appears abnormal shape, then probably there is some kind of penetrating injury. And if let's say the pupil in the normal size, it should be around 3 to 4 millimeter, but if you see the patient is widely dilated, then think about there could be a blunt trauma happening to the patient, which might causes damage to the sphincter, or even any damage on the iris tissue. Look for any foreign body. Look for the presence of blood in the anterior chamber, or we call it hyphema. At the same time, with the torch, we can also assess the what we call a relative afferent pupillary defect, the reaction of the pupil towards the light that you shine to the eye. So in normal situation, when you shine a bright light, the pupil should constrict, becomes to the size of 2 to 3 millimeter, and sustain that constriction as long as you shine the light to the eye. But if let's say in a situation whereby there's a damage of the optic nerve, such as in optic neuropathy, what will happen is if you shine the light to the affected eye, instead of constricting, it will be dilating. So when you have this what we call a relative afferent pupillary defect, means relatively one eye is more dilated than the other eye. When you shine the light, that means RAPD positive, think about the possibility of optic nerve damage. Now, how to use our ophthalmoscope? Of course, we can actually use it not only to examine the red reflex, but we can also use it to evaluate the fundus of the patient. I know funduscopy can be quite difficult, and in trauma situations, sometimes we do not encourage you to dilate the eyes. Don't put any dilating drop, because it can be something that it could be a penetrating injury in which you should not put any eye drop. So try not to dilate. So if you can't see the fundus, that's fine, but at least use the ophthalmoscope, shine the light with the direct ophthalmoscope, and see through the ophthalmoscope itself. What we are trying to see is the presence of a good red reflex. Red reflex is actually a light which is being reflected by the retina, an intact retina. So it should be very bright, orange color. But if let's say you compare with the affected eye, you can see the red reflex is much reduced. We'll think of some opacity within the pathway of the light, which could be either vitreous hemorrhage, bleeding in the anterior part of the lens, which is the anterior chamber, or it could be retinal detachment. So red reflex is also one of the way that we use in our own clinic to judge the potential damage that might occur inside the eye. Now, this is what happened during blind trauma. Whenever the eye is being hit by an object, particularly smaller than the opening of the orbit, the eyeball will expand, and the force will potentially causes a various kind of injury, almost in all parts of the eye, which also include the orbital wall itself. Now, let's look at the detail of the injury itself after a blunt trauma. So, a blunt trauma can cause a damage to the iris tissue. What can it do? It can cause iridodialysis, or actually a separation of the iris root from its attachment. So you can see a second pupil. So patient will complain of reduced vision, glare, and sometimes double vision. And if it's bad enough, you might have concurrent. You can see that in the first photo, the lens is quite clear. Here you can see it's a big cataractus, so they can have immediate cataract after the trauma. And you can see there's a very large iridodialysis here and a very dilated pupil. Again, they will complain of reduced vision. Now, another situation is what we call blood inside the anterior chamber. You can either have a small level of blood inferiorly and you can still see the pupil, or in a severe situation you might just see the whole eyeball is filled up with the whole anterior chamber is filled up with blood, or we call it total hyphema. So you are not able to see the pupil, you will not be able to assess the size of the pupil, vision will be markedly reduced. In this situation, usually the vision might be just counting finger or hand motion, so they will not be able to read your Snellen chart. Now, in certain situations like this, what we do when there's this insertion of the iris tissue, we will do surgical correction. And if there's cataractus, we remove the lens and replace it with the intraocular lens. So this kind of surgery can be an elective surgery, which is fine. But then, if there is a hyphema, this is potentially can be a emergency situation for us. What will happen is the blood clot will actually block the drainage system inside the eye. So what happens is the pressure inside the eye, or we call it as intraocular pressure, will increase and eventually causes pain to the patient. It damages the optic nerve because of the high pressure, and it also can stain the cornea. So a clear cornea can become opaque because the presence of blood with high pressure inside the eye. So this could be an emergency situation. So if you can't see the pupil, patient complain of pain, refer the patient immediately on the same day. Injury after the burn trauma. What happened is, okay, let me just recap. This is a normal looking fundus. This is the optic disc with the blood vessels in all quadrant. This tigroid appearance tells you that the retina is completely attached. With a blood trauma, patient can have vitreous hemorrhage, so patient will be complaining of seeing floaters and flashes at the same time, and the vision will be reduced. And if you do the red reflex examination using an ophthalmoscope, you will get a reduced red reflex. The next thing is, if let's say the contusion is too strong, or the effect is too strong, patient might end up having the separation of the vitreous gel and eventually tears off the retina. And this is a retinal tear, a big one, a small one, with associated retinal detachment. You can see there's loss of the tigroid fundus. You can see some kind of this is a tigroid pattern in a normal fundus, and you don't see it here, so it just tells you the retina has detached. In this situation, the RAPD is positive, relative afferent pupillary defect will be positive, vision will be reduced, and the red reflex will also be reduced. Now, in traumatic optic neuropathy, this is a contusion of the retina, the surrounding retina, so it's edematous. But then at the same time, if let's say the trauma is the force is quite strong, it might also transfer the force onto the optic nerve. So patient will present with reduced vision, positive RAPD. That means the pupillary reflex will be abnormal, and then there will be central scotoma, and these patients usually requires an intravenous metaprednisolone for traumatic optic neuropathy. For vitreous hemorrhage, what do? We usually advise them to observe if it's not so bad. But if let's say it is very bad, it fills up the whole cavity, and there is an association with a retinal tear or detachment, then surgery is mandatory, either on the same day or the next day. Now, lamellar injury, patient usually will complain of reduced vision and eye pain. So it is important to remind ourselves that we need to make sure it is a definite lamellar injury and it's not an open wound. How do we know that? Well, if you shine a bright torch, you can actually see probably some, it's a bit difficult to see whether the thickness is full thickness laceration or is it a lamellar thickness laceration. If you're not sure, just send the patient off. But if let's say you can clearly see that the superficial layer is abraded, the eyeball is still, the vision is still good, and pupil is still round, red reflex is good, no RAPD. Usually what we do is we treat patient with topical antibiotic and lubrication. But if there is an open wound, these two treatment of antibiotic and lubricating drop is going to be detrimental to the eye. Now, for open group injury, either penetrating injury, perforating injury, or those with the intraocular foreign body, this patient requires immediate attention, immediate referral. So what will happen is we will need to close the wound as soon as possible when you reach the hospital. The longer we keep the wound open, the higher chances the eyeball will collapse and the content of the eyeball will prolapse out. Even worse, they might get into a expulsive hemorrhage, so it's just bleeding profusely from the eyeball itself. So what will prolapse out potentially is the retina, the choroid, and even the vitreous gel. So the longer we keep the eyeball open, the higher chances of infection inside the eye as well. So what do we do? Let's look at the do's and don'ts. So when we suspect there's an open group injury, of course, I'm sure doctors will refer the patient immediately. But at least these are the do's and don'ts, and hopefully we try to avoid doing this. Number one, do not pat the eye. Do not compress the eye. If let's say there's a bleeding, do not sort of try to stop the bleeding by giving any compression. This will just increase the pressure on the eyeball and exaggerate the if let's say there's a prolapse of tissue, it will just induce a lot more tissue extrusion from the eyeball. Now, eye drops itself is also, please do not prescribe any eye drop. If you want to give the patient anti-tetanus, yes. If you want to give patient systemic antibiotic, yes, but not any topical eye drops, antibiotic, or even topical steroid. What we encourage to do is actually to create a moist chamber. Sometimes you can just refashion the paper cup to just put it over the eye and put a sticky tape around it, just to protect the eye from any pressure from outside, and advise the patient to keep nail by mouth from the moment you see the patient. So because most of the time for this kind of cases, we do it under general anesthesia. So imagine if let's say the patient still eats by the time they arrive at the hospital, so we have to delay the surgery probably 6 hours after that. So try to keep the patient nail by mouth. With then, thank you. Before I forget, I would like to take this opportunity to introduce our YouTube channel of the department. So hopefully there will be some relevant videos for the primary doctors, and thank you.